or nateglinide could be utilized in addition to decreasing cardiovascular risk to decrease the incidence of evolution of diabetes in patients who had impaired glucose tolerance. And surprisingly, the nateglinide arm did not reduce diabetic evolution, and in fact increased it a little bit, but not statistically significantly. Very surprisingly, and maybe not too significant in the big picture, in that it wasn't evaluated for in a primary powered way, was the fact that there was a relative reduction in incidence of diabetes in the valsartan arm, which was unexplained, but there was not a reduction in primary cardiovascular endpoints, which dispelled a myth some of the investigators thought. This is in graphic form that the valsartan arm shows a lower development of diabetes over time in these patients who had impaired glucose tolerance but not truly called diabetics upon admission into the trial. And this shows the nateglinide failure to prevent diabetic evolution in that same cohort of patients. The ASCOT trial was a blood pressure lowering arm, and you may see a theme here. We're starting to see, well, geez, let's get the blood pressure down. Maybe we should get it really low down. And let's also now look at advantages in patients who are going to have issues related to blood pressure management by different agents. And this is looking at blood pressure control utilizing amlodipine versus beta blocker, and with or without other agents, including diuretics. The most interesting thing that came out of this is the most important finding was that it is actually the variability in blood pressure in the office visit that predicted an adverse cardiovascular outcome. So if you have a patient that you think is under good control and one time you see them in the office, the blood pressure is 140, but then it's 190, the next visit, that's a very bad marker. And also, amlodipine was a better agent than atenolol at preventing cardiovascular events, including stroke and coronaries. The INVEST trial was another interesting trial that looked at lower blood pressure goals in patients who already have known coronary disease. Again, the theme being, let's see if we really drive the blood pressure down, is this going to further benefit the patients who have been identified already as having coronary disease? And it turned out, to the surprise of these investigators, and their tight control was less than 115 systolic. So in established diabetics with established coronary disease diagnosis, it turned out there was higher adverse event occurrence in patients when the blood pressure was driven to under 115 versus allowed to stay in the 130 to 140 range. A genetic test study was the Medco-Mayo study looking at the actual use of the cytochrome activation gene to see if we can predict which patient's dose is going to be best when warfarin is initiated. And they genotyped about 500 patients going on warfarin and tried to look at hospital readmissions and bleeding events, and there was a sizable decrease in hospitalizations in the patients in whom they had done this testing. However, there were a couple problems with it. One of the biggest issues was the time it took to get the test result back. And if you think about it, this was looking at a group of patients who were being initiated on warfarin. And you want to know that result right away, because that's when the greatest hazard may well be, when you're initiating therapy. But the results came back later in the study for these patients, and perhaps there was just extra vigilance. It was not a prospective randomized trial, but it did clearly identify patients' likely safer dose range requirement from genetic testing. And a larger study apparently is going to be launched out of that. Valvular heart disease was a most interesting session. Blaise Carabello was the leader of that group, and many of you are well aware of the Everest-2 trial that was highlighted at this meeting. And it was a randomized trial looking at the clip, which is designed to mimic what Ottavio Alfieri of Italy devised as a simple repair of a very simple subtype of mitral regurgitation, which is basically central regurgitation without a flail leaflet or without some other organic pathology of the valve. Dr. Alfieri has said in national meetings that he subsequently learned that if that's all you do to repair a valve that's leaking with that kind of pathology, only 10% of the patients will have success past a year or two. And so he usually does something else. However, it's a novel treatment idea, and this clip was evolved, and it went through phase 1 trials, and this then wound up in a larger trial that was randomized, which is pretty remarkable, and they did a nice job randomizing the patients with a 2-to-1 ratio, the control group being the surgical group. And 178 patients were treated with the clip, and 80 were treated with surgery. And they followed these patients out for a year, and they had very good evaluation, echocardiographically blinded, although it really couldn't be blinded because you can see the clip or you can see the surgery. But it was a blinding, the lab was outside, and the one thing that was most striking is the adverse event rates that they claimed for the surgical group versus the trial group. The surgical group, they claimed 57%, or they added 57%, in large part because they counted as a major adverse event a transfusion greater than 2 units. And that is significant. Many would say that maybe that shouldn't be counted, but even so, there would still be more major adverse events in the surgical group. If you look at how they succeeded, they actually did quite well. The device group, those getting that clip on the mitral A2 to P2, it turns out had 3 to 4 plus mitral coming in a similar proportion to those who underwent the surgery, and their success was called 2 plus or less. In the surgical group, there were very few 2 plus or lesses, because most surgeons would say if we were leaving the OR with 2 plus, we would not get referred very many patients for a repair. However, that being said, they did succeed in getting a lot of patients improve significantly with their MR fraction from 3 to 4 plus down to 2 plus or less, which is quite remarkable. Now, does this mean that we are going to be able to say this is also ready for prime time? And actually, many have asked these questions already. And has there been sufficient efficacy demonstrated in this trial to support approval by the FDA of this clip? And is 1 year efficacy sufficient to recommend the mitral clip? They did also look at volumes of the ventricle, and very interestingly, the left end diastolic volumes and systolic volumes at 1 year were virtually identical, which is quite impressive also. Now, is the surgery clip a valid alternative to mitral surgery in selected patients with MR? And should we only consider it for degenerative MR? And should we consider it in people who are good surgical candidates? Should we consider it for people who are poor surgical candidates? And what about functional MR? So there are a lot of unknown questions, and the durability is unknown, and these are actually Blaise Carabello's questions. We don't know, although it may be an unimportant question about durability in some patients. If we have some frail elderly individual who is being admitted frequently for uncontrollable heart failure, if we could take them from 4 plus to 2 plus, maybe that'll help them stay out of the hospital for the remaining time they have. If late failure occurs, another one of Blaise Carabello's questions, is repair still an option? And that isn't clear yet, because the repair is still obviously the best option if it's a repairable valve. And this is mostly for patients with degenerative disease, which are repairable valves. Transcatheter aortic valve you've heard about frequently here today, and at this meeting it's an interesting new, rapidly emerging technology. There have been numerous implants around the world, and I just put this one up. We actually had a very interesting session where there was discussion about transapical versus transperipheral catheter implantation by Dr. Bahanian on the peripheral and Dr. Bavaria on the transapical. And the transapical approach in their hands at University of Pennsylvania, they actually did Doppler cranial monitoring when they went either transfemoral or transapical. And it turns out they had an enormous number of hits to the brain when they went transfemoral, because most of these patients being offered transcatheter aortic valves are being turned down for surgery because they have porcelain aortas and very heavy atherosclerotic load. And the guiding catheter wires for these valves are very big and stiff. And you can just see them excavating across the arch. However, the transcatheter valves do have great efficacy. I think it's a great new technology. We just have to be careful about in whom we implant it and how we implant it when it's selected. And a very important message that continued to come from several series was the early mortality in many very experienced investigators' hands fell from 13 to 6.5% over their learning curves. And it's very important when we do risk assessment of patients that we look at the whole patient. Each patient's an individual. And some have said that some of the patients included in trials were not necessarily inoperable patients. However, I think that the investigators have done a very good job of being very cautious about screening these patients appropriately. And not every 90-year-old is inoperable, but not every 70-year-old is operable. So I think that's where judgment and wisdom come in, and we work collegially to come to the right answer for some of these patients. Cardiac function and heart failure was also a very popular area, led by Dr. Doug Mann. And one of the studies that came out, which was a very simple, interesting study that hadn't been done before, and it was one of those studies that everyone sort of thought, geez, why wasn't this done before? Which is basically looking at patients with acute decompensated heart failure coming into the hospital. Is it better to give them high dose or low dose diuretic? Is it better to give it intravenously or give it as a bolus or give it as a continuous infusion? And several different assessment scores were utilized in these patients. They basically were the visual assessment score, the congestive heart failure visual assessment score, and area under the curve. And it turns out there wasn't much difference in the dose or the route of the way it was administered. What about creatinine changes? Unfortunately, these creatinine studies were only done out to the hospital stay, which for most patients was less than 4 to 5 days. And we don't know what the creatinines were at a month. However, there were not statistically significant differences in creatinine changes from continuous infusion versus bolus infusion and versus low dose versus high dose. So the bottom line is it didn't seem to matter what you did, and you just basically look at the weight loss and how their heart failure symptoms are going, and it gives one free range to do either management strategy that you feel most comfortable with. So we now have some evidence that it doesn't seem to matter how you treat the patient in terms of heart failure with a diuretic, in terms of continuous versus bolus. And this is just looking at some of the other changes in creatinine in different ways. Symptom relief was also looked at in this group, and there was no change in any of these, although there were some trends for improvement in symptom relief, but nothing statistically significant. And some of those are very hard to objectify. Late-breaking clinical trials also discussed in discussion afterwards what about the creatinines of these patients, because some of these patients are frail, and a 1.6 in a frail small BMI individual is not the same as a large individual. And we don't know about the equipotency of some of the doses, but I think we did get the answer from the trial. Surgical restoration of the ventricle was revisited again, even though it had been previously presented the year before, the Stitch trial, the year before by Robert Jones. This year it was presented by Robert Mitchler. And the Stitch trial was looking at whether or not CABG plus volume restoration, surgical ventricular restoration, benefits patients who have reduced ejection fractions and significant areas of dysfunction of their LV. And as you may recall from 2009, this large series that was done in multiple centers showed actually no difference in morbidity or mortality. In fact, maybe slightly higher morbidity in the Stitch patients and certainly higher cost. So it turned out that it was felt not to be a reasonable option, although there was enormous controversy about that, and the Stitch trial data was reevaluated. And this is just showing, should we just do a coronary revascularization and forget about a ventricular dysfunction, or should we do a ventricular restoration procedure where the dysfunctional zone is removed and cavity size is carefully assessed and reconstructed? And the premise for this redigging of the data on the Stitch trial was that perhaps the patients who had the very large ventricles coming into the study were the ones that were going to benefit the most. So let's go back and look at the patients with the very large ventricles, and I'll bet they're going to be the ones who came out at the other end better off having had ventricular restoration surgically. And it turned out